Lymphoma Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the Lymphoma Hub podcast. Today we'll be hearing from Chan Cheah of the University of Western Australia in Perth, Australia.
Hello, my name is Chan Cheah. I'm a haematologist at St Charles Gairdner Hospital in Perth, Western Australia. And I'd like to update you all about some interesting data which is going to be presented at the upcoming American Society of Hematology meeting, which is taking place in New Orleans, and specifically highlighting some of the novel therapies which are active in patients with chronic lymphocytic leukemia. As you know, non-chemotherapy strategies using covalent BTK inhibitors and venetoclax, which is a BCL2 inhibitor, have become widely used and really are standard of care now across multiple lines of therapy. However, these treatments are not curative, and for patients who experience relapse or progression following either venetoclax-based therapy or covalent BTK inhibitors, there is still significant unmet medical need. In terms of the novel therapies for this, we've got quite a few presentations which are taking place at the meeting. In particular, these can be broken down into a number of different subclasses. We've got non-covalent BTK inhibitors, which are oral agents which bind to BTK in a reversible fashion, but are non-covalent. And the leading example in this category is called pirtobrutinib, previously known as LOXO 305. We also are going to see a presentation from Anthony Mato about a new type of BTK therapy, which is a BTK protein degrader. And he's going to be presenting some data on an example of this called NX2127, which combines BTK protein degradation with inhibition of Ikaros-like zinc factor 3 or IKZF3 in heavily pretreated patients with largely with covalent and BCL2 inhibitor refractory CLL. On the topic of BCL2 inhibitors, we are seeing some data about novel BCL2 inhibitors being presented as well. Matthew Davids from Dana-Farber will be presenting on lisaftuclax, which is a novel BCL2 inhibitor, and the phase 1/2 study includes now around 140 patients treated with both lisaftuclax as monotherapy and also in combination with acalabrutinib and rituximab. From what I've seen from the abstract, the data for this agent certainly appear promising, with reasonable response rates, no unexpected toxicity signals, and the ability to be combined with both acalabrutinib and rituximab without leading to any unexpected problems, and excellent efficacy. I'll be presenting on BGB-11417, which is another novel BCL2 inhibitor, and the data that I will be presenting will be a combination of both monotherapy of this agent and in combination with zanubrutinib, which of course is a covalent BTK inhibitor. So we've treated quite a few patients with relapsed and refractory and treatment-naive CLL now on this study, about 79, and we have seen certainly encouraging response rates. BGB-11417 is more potent than venetoclax in terms of BCL2 inhibition, and we have not seen significant GI toxicity. So the nausea and the diarrhea and things like that, which are seen at higher doses of venetoclax, have not been a major problem so far. The drug has been active. We've seen very encouraging response rates and MRD negative response rates. And when combined with zanubrutinib in the treatment-naive setting, we've seen excellent disease control with the vast majority of patients remaining on study. So this novel BCL2 inhibitor, BGB-11417, certainly appears to be another novel agent which will be useful for patients with CLL. And our preclinical data suggests that this is going to have activity in venetoclax refractory patients as well. And a venetoclax exposed arm on this study is going to open soon. I mentioned pirtobrutinib earlier, and pirtobrutinib has been around now for a few years, and the primary publication of the LOXO 305 study was now about a year and a half ago, I think, in Lancet. There will be a couple of interesting data updates for pirtobrutinib at this meeting, including a longer follow-up on the 276 patients treated on the phase 1/2 BRUIN study. As you recall, patients were fairly heavily pretreated, 3 prior lines of therapy, and the excellent response rates at around 74% and durability continue to stretch out there. So certainly the use of non-covalent BTK inhibitors appear to be a major advance in the treatment of patients who are refractory to drugs like ibrutinib, acalabrutinib, and zanubrutinib, and also venetoclax. And I think it's very likely that we'll see some regulatory approvals for this agent soon. The other thing that I'd like to highlight listeners' attention to is a slightly smaller arm of the BRUIN study using pirtobrutinib in a cohort of patients with Richter transformation. Now, of course, strictly speaking, Richter transformation is not CLL, but it is a complication of CLL and has a pretty uniformly adverse prognosis with a median survival of around 12 months. And so certainly Richter transformation is a group of patients who are urgently in need of better therapies. So there will be a presentation of pirtobrutinib in patients with Richter transformation, mostly previously treated, although a couple of treatment-naive patients were included after a protocol amendment. A pretty large study for Richters. I think we included 57 patients in this study with a median of 2 prior lines. And pirtobrutinib was surprisingly active. The objective response rate was 54% with a median duration of response of about 8 months. And more encouraging was that, like in other settings where pirtobrutinib is used, the toxicity profile was very favorable, and the rates of grade 3 or higher adverse events were very low. Pirtobrutinib is a very well-tolerated drug. And although it doesn't appear to be curative, it certainly looks like it may be a useful strategy for patients who are, often these patients are very sick. And I put a number of patients on this study who had very high tumor burden, explosive symptoms, and completely chemotherapy refractory. So for a once-a-day tablet with a very favorable side effect profile, that kind of response rate is, I think, very encouraging and suggests that the pirtobrutinib may be useful both in future combinations and as a potential bridge to more definitive therapies like chimeric antigen receptor T-cell therapy or allogeneic stem cell transplantation. So, of course, I'm looking forward to seeing the detail in all of these presentations, that is those which I'm not involved in personally. And I hope everyone gets a chance to go through the data after the meeting. Thanks very much for your attention.
Thank you for listening to the Lymphoma Hub podcast. We would also like to thank our supporters, Bristol Myers Squibb, Genentech, Insight, Pharmacyclics, Roche, Novartis, AstraZeneca, and Beijing.
Lymphoma Hub podcasts, brought to you by Scientific Education Support.